This conference will now be recorded.
Good morning, students. Am I audible? One of you respond.
Yes, ma'am.
Am I audible? Okay, what do you mean by post-term pregnancy? What do you mean by it? The name itself is telling no. Post-term pregnancy. What is term? Then tell me what is preterm. One of you respond. What is preterm? What is early preterm and what is late preterm? Audible or not? Am I audible? One of you respond.
Yes, ma'am.
Have you heard the word or not? Preterm. So how will you calculate? Whenever a patient comes to you, first of all, you have to know what is her gestational age. How will you calculate the gestational age? Based on LMP, right? How will you calculate? You add 9 months plus 7 days and you call it as Nagli's formula. And this is fit only for the women who have regular cycles. So a antenatal patient came to you and you calculated her expected date of delivery. Immediately the patient asks you, right, when I'm going to deliver. So you will calculate, and according to Nagli's formula, we will take it as complete 40 weeks as term, and before 37 weeks you call it as preterm. Okay, so there are situations when she enters into labor even she's not finished her 37 weeks, so that is preterm labor. And there are conditions where she won't enter into labor even after completing of 40 weeks, 41 weeks or 42 weeks also. Okay, that you call it as post-term pregnancy. So what happens? Which is problematic, preterm or post-term? What complications you can expect with a preterm labor? Will there be any difference for the mother? So the preterm labor, majorly we are concerned with the baby, because the baby is not completely matured and it might not be able to be compatible like that of a term baby. So there is every chance of more infections and less the probability of surviving and more the chance of perinatal morbidity and mortality in case of a preterm baby, but there won't be much problem with that of mother. But here in case of post-term pregnancy, as she's advancing her dates, what happens majorly is the baby overgrows here and the amount of lighter decreases and the baby matures more. So here with the post-maturity or post-term pregnancy, both the mother and baby will be facing the complications. So after completing the term or completing the days, the baby won't be able to be surviving inside the uterus. It is harmful to the baby. And as the baby is overgrowing, the mother will develop difficult delivery. There is more need of instrumental delivery, more chances of shoulder dystocia, and more chances of higher the cesarean section also. Not only that, as the baby overgrows, there is higher perinatal morbidity and mortality and more the incidence of stillbirth also. So whenever a patient comes to you and you calculated the expected date of delivery, you found that it is 42 weeks. Immediately what will you do? Your Nagli's formula showing it is 42 weeks. What next step? Or if the you examine the patient and the abdomen is showing only 36 weeks and according to your calculation it is like 41 weeks, what will you do? Immediately, the most common cause and the first to be ruled out cause is also wrong dates. So most of the women might not be sure of their LMP. So you have to recheck the LMP, ask her again. If she's not able to recollect, you have to link it up with some festival or you try to test out the LMP. If not possible, then you have to go for early scans, means first trimester scan. You call it as dating scan. Why? Because it is helpful in calculating the dates accurately. When patient is not sure of her LMP, you can take the help of dating scan. When this LMP and this dating scan is corresponding, then you have to think of this post-term pregnancy, or she might be sure of her dates. Okay, so definition, it is after completion of complete 42 weeks of gestation, or in days count it is more than 294 days. What is the incidence? So it is 4 to 14% in incidence, and by LMP, if you take by LMP, it will be 7.5%. And if you go by ultrasonography, by your early scan, when you don't know the LMP, you come to the post-term pregnancy in about 2.6% of the cases. When you combine both LMP and ultrasonography, you take the help of both, then you will get a 1.1% incidence, because combining LMP and USG gives you a more correct diagnosis. And like preterm pregnancy, if a woman had once preterm pregnancy, in subsequent pregnancies also she has the tendency to go into preterm again. So like this, here also if she is a post-term pregnancy in first pregnancy, the successive pregnancies also she is prone to be post-term. So previously if she had one post-term pregnancy, this time in current pregnancy, there is 27% chance she may go into post-term pregnancy. And if previously 2 post-term pregnancies, this time there is chance of 39%. So like preterm pregnancy, post-term pregnancy also carry on in pregnancies. So what is the etiology? The first most common and the first to be ruled out is wrong dates, because inaccurate LMP. So the patient might not be able to recollect her LMP, and that is why we are getting more gestational age. Biological variability, like heredity, like if her mother is having history of post-term pregnancies, there is a little chance this girl also can have this post-term pregnancy. And maternal factors, one more important, irregular ovulation, means like if she is a case of PCOD, okay, she has cycles every 2-3 months. This time she remembers her LMP, she's very sure of her LMP, and you calculate according to your Neglis formula like 9 months and 7 days, which is fit only for regular cycles. But this woman is having irregular cycles, and you cannot exactly predict the period of ovulation. When this ovulation occurs 14 days prior to the onset of next cycle. That is for who have regular cycles. But here we cannot predict what is the period of ovulation, or if she is in lactational amenorrhea, or if she is on some other methods of contraception. These are the conditions where we cannot predict the exact time of ovulation. So then also you have to rely on the first trimester ultrasonography again. And primiparous women or elderly multipara. So these are some maternal factors. And next, decreased fetal estrogen production, placental sulfatase deficiency, anencephaly, and fetal adrenal hypoplasia, because decreased cortisol response, because these hormones are responsible for initiation of labor. When the girl enters into term, so for the labor to start, this cortisol and sulfatase, these enzymes are essential for initiation of labor. So because of failure of these initiation mechanisms, now she may enter into labor, and she will cross for 40 weeks. And very, very rare is extrauterine pregnancy. Means if it is an extrauterine, means you all know it is ectopic. Ectopic pregnancy, usually in early weeks itself it will be diagnosed, right? If it is now we have ultrasound and all, you can diagnose early, or rupture ectopic also, it's an emergency, we will be diagnosed. So extrauterine pregnancy may be an abdominal pregnancy, that too coming to term and going to post dates, that is very, very rare condition. Okay, so how will you diagnose? The important dates to determine. So you are trying to make the patient recollect the gestation age based on, first we will ask about the LMP. If she is able to recollect, fine. Or you will go for early ultrasound, early dating ultrasound. It helps in tracing out the dates. Or you can still ask about the timing of intercourse. If she is able to recollect, then also we can calculate the dates. And also most important is menstrual history, because regular cycles only we will be able to calculate all these dates. Okay, and clinical findings, you can check on the weight recordings of the patient and girth of the abdomen. So the abdomen girth then gradually decreases. After 40 weeks of gestation, the amount of liquor will start decreasing. So the abdominal girth also decreases. And if she has any history of false pains, some history of appearance of false pains also maybe suggest to she is towards term, because term only they'll experience false pain. What are the causes of this false pain? Maybe incomplete bowel emptying, loaded rectum. So this can be the cause for false pain. What are the differences between true and false pain? If it is a true labor pain, there will be progressive increasing intensity and frequency of the uterine contractions, and that is associated with progressive cervical changes. So the contractions will increase in intensity. But these false pains will be irregular. Sometimes it will be strong, sometimes it will be light, and not increasing with time, and not at all any cervical changes. So these are false pains. So simple enema can relieve her from these false pains. And next, obstetric examination. On palpation, what will you see? Any antenatal case? First of all, height of the uterus. Next, size of the fetus. How big is the baby? Is it appearing to be a too big baby or post-term baby or a small baby? And hardness of the skull bones. So compared to a preterm baby, term baby head will be harder. Preterm head will be soft. So compared to this term baby head, our post-term baby head will be still more harder because the baby is growing. So you try to elicit the hardness of the skull bones, and here the uterus feels full of fetus. This is also a feature associated with post-maturity. Why? Because we told there will be decrease in the amount of liquor after 40 weeks of gestation. So as the amount of liquor is less, you will be able to palpating full of fetus abdomen. So like in case of our oligohydramnios, when we examine a case of oligohydramnios also, you will completely palpate the fetal parts. So if the amniotic fluid is good, you won't be palpating completely like that. If the amniotic fluid is too high, you even can't appreciate the fetal parts. The abdomen is over distended, tense, and it is completely fluid. So you cannot even differentiate the parts also. So here the amount of liquor will be less and the baby will be overgrowing. You will notice like something full of fetus abdomen. And next you go for your PE, internal examination. So if the cervix is ripe, means this is suggestion of fetal maturity. Ripe cervix means it reached term or post-term, and so the baby is also mature. But unripe cervix, this doesn't exclude maturity. There are situations where it's already post-term, mature, but the cervix is not ripened and not entered into labor. So if there is a ripened cervix, it is suggestive of your maturity. But unripe cervix, you cannot completely rule out post-maturity. And feeling of harder skull bones through the cervix, again pointing towards maturity of the baby. Okay. So after your examination, you have to confirm. So you have investigations to confirm fetal maturity, and you have to detect if there is any placental insufficiency. How will you assess fetal maturity? The helping, the most common what we do investigation is ultrasonography. So here the estimation of gestational age by ultrasonography is more accurate. How will you calculate gestational age by ultrasound? In first trimester, we will take the help of Cron drum plan. Next, second trimester, what will you take? Biparietal diameter. Okay. Next, you take off head circumference, abdominal circumference, femur length. So these are the parameters which measurements we take on ultrasound, and with the help of these, you will calculate the gestational age and also the weight of the baby. So when you have the doubt of the post maturity, now you take an ultrasound and it will give you the gestational age of the baby now. And next, some invasive method called amniocentesis, because in the amniocentesis you take the sample of amniotic fluid and you can detect about maturity of the baby. So determination of the fetal maturity. So when you have the suspicion or doubt of your post maturity, the three most important dates you have to recollect, as we told, are first date of LMP, and the dating of early ultrasound, and the timing of intercourse. If she is able to recollect, fine. Next, you go for your clinical thing. Clinically, you can again probe into LMP or auscultation of fetal heart rate. Around 17 to 20 weeks, first time fetal heart will be heard. So you can ask her when this, or if she has any documentation, you can see when her fetal heart was heard. And fundal height of the uterus you can calculate. Next, feel of the head, whether it is soft, hard, or still harder, and the amount of liquor, more or less, and the cervical condition, whether it is ripened cervix, favorable cervix, or not at all any cervical changes. These are the clinical examination of abdomen and cervix. Next, coming to our investigation part, we have non-invasive and invasive. Non-invasive means our ultrasonography. So first trimester ultrasound, how it help? Crown rump length. And this first trimester ultrasound also we can have a variation of plus or minus 5 days. Means there is less than 5 days of difference between her LMP and first trimester scan. You can go with the LMP. So if she's not sure of her LMP or some lactation amenorrhea or contraception, you can directly go with the first trimester ultrasonography for dating. And in case of second trimester, you will calculate biparietal diameter and female length of the fetus. Here the variation of 7 to 10 days is acceptable. Okay, and biparietal diameter, and here a variation can be there in case of sonography. So compared to variation also, the first trimester ultrasound always will be more accurate towards the diagnosis and dating. And next, the amniotic fluid volume. So after term, the amniotic fluid volume AF5, also amniotic fluid index decreases. So these are non-invasive things. What we can do is ultrasonography. So invasive thing, amniocentesis, we routinely won't practice. Amniocentesis is we take the sample of amniotic fluid with the help of a needle, can be ultrasound guided. So here you can see orange color cells, presence of phosphatidylglycerol, listening sphingomyelin ratio, lamellar body count. These are all the tests for fetal maturity. Okay, so these indicate whether the baby is mature or not. Okay, so you're all familiar with these abbreviations, right? CRL is crown rump length, biparietal diameter. You will measure with the help of ultrasound in centimeters. Abdominal circumference, head circumference, and femur length. As the baby is young, towards first trimester, the most accurate thing we will have is crown rump length. And as the baby is towards term, means starting from second trimester itself, the most important and more closer thing is femur length. Femur length gives us the more accurate gestational age. Okay. So how will you do antepartum fetal surveillance for any case? For any women, we will advise fetal movement count. You call it as DFMC, daily fetal movement count. So how will you do? You ask the patient to count the fetal movements or 1 hour, twice or thrice a day. Means you give the patient pen and paper. Okay, ask her to count the movements of baby 1 hour after food, means 1 hour after breakfast, 1 hour after lunch, and 1 hour after dinner. Lie down, put her hand on the abdomen and count how many times the baby is moving. So on an average, full day, she must have more than 12 movements. So less than 12 movements, you have to ask her to report immediately. So means the baby is moving means baby is good. Okay, that is one part of fetal surveillance. And next, when she comes to you, you can do amniotic fluid assessment. How will you do amniotic fluid assessment? Ultrasound again. In ultrasound, how will you calculate AF5? You divide the abdomen into 4 quadrants. Okay, Q1, Q2, Q3, Q4. So each quadrant, you will calculate the deepest vertical point. Like that. So you sum all these Q1, Q2, Q3, Q4, and its normal range is 5 to 25. So anything below 5, you take it as oligohydramnios, means less the lighter, and more than 25, you take it as polyhydramnios. So if the AFI is less than 5, so it's abnormal. Or single deepest pocket is less than 2 centimeters also, again towards oligohydramnios. So along with asking her to check for the movements, you can check for the amniotic fluid assessment also. Then we have NST. What is NST? non-stress test. So how will you do? So you can start from as early as 33 weeks. If it's a high risk case, a bit earlier also. But to get a proper NST, reactive NST, it should be more than 34 weeks. So how will you connect? We have two probes, Stoco probe and fetal heart probe. So you locate the fetal heart with the help of stethoscope and put the probe on it by applying a gel and connect, run the trace for 20 minutes. You give a small probe to the patient hand and you ask her to press on it whenever there is baby movement. So usually accelerations in the NST correspond to baby movement. So when you call it as reactive, so it must in a 20 minutes trace, there must be 2 or more accelerations. Acceleration is more than 15 beats it has to rise, fetal heart rate, and it has to sustain at least for 10-15 seconds. So 2 or more accelerations in 20 minutes time is a good sign. No decelerations. Decelerations are a bad sign, and there should be 5 to 15 beats variability. Okay, so and you have to take a baseline. Baseline means most of the time, what is the fetal heart rate, around which range you take it as baseline. That is how you perform NST. Okay, if the NST is reassuring, good. Non-reassuring means you have some doubt, some problem is there with the baby. Then what will you do? You have to go for biophysical profile. What is it? Biophysical profile is an investigation. This is also again with the help of ultrasound. Okay. Here what we do is, this is a time-taking investigation. It takes like 30 minutes, over 30 minutes of time, we will assess the baby. What we assess? So we will assess the amniotic fluid index again, and we will assess the breathing movements of the baby, and we assess the gross motor movements of the baby, means tone. Once a limb is flexed and extended, you take it as tone. Okay. Next, here also NST is important. So these parameters all come under biophysical profile. So we have a scoring of 10 for this biophysical profile. 8 or more, you take it as normal. Each have 2 score. And if it is less, there is again some problem with the baby. There is one thing called modified biophysical profile. Here only 2 parameters we take, that is NST and AFI. So NST is reactive, amniotic fluid index is good. So modified biophysical profile is good, reactive. So these 2 can be used in case of modified biophysical profile. And if you still have doubt or some problem with the baby or placental insufficiency you suspect, if she's a case of hypertension or some other thing, then you have to go for Doppler studies also. So the diagnosis of post-maturity after birth of the baby. So how the baby looks after birth? The baby looks thin and there will be old looking. The skin is ringed. See the diagram. And the absence of vernix caseosa. Vernix caseosa also decreases after term. The body and the cord will be stained yellow color and the head is hard. And there won't be any evidence of molding also, because the harder bones, overgrown bones, won't be able to molding like in case of a routine term head. Okay, and the nails also protruding beyond the nail beds. See in the diagram. And usually these babies will be more than 3 kgs and length will be more than 54 centimeters. But there can be an IUGR baby also. The baby is post-term. Dates are more, but it can be intrauterine growth restrictions. So there can be a lesser weight baby also. So the typical old look, thin look, lesser vernix caseosa, wrinkled skins, and the nails beyond the nail beds. There can be greenish discoloration of the skin and the cord, because most of the times this post-maturity is associated with meconium stain liquor, and the babies have the chance of meconium aspiration also. So this discoloration. See, post-maturity syndrome, this develops in 20% of the pregnancies, and newborn who has dry peeled skin coated with meconium, greenish meconium, and the overgrown nails and scalp hair will be more grown, and palmar creases and sole creases will be more developed, and vernix will be little or absent. Minimal subcutaneous fat. The baby won't be chubby like our case, our term baby. It won't be chubby. There is lesser subcutaneous fat, and such picture indicates the baby is at malnourishment in the uterus. and this is independent of gestation. Maybe sometimes this post-maturity syndrome can be seen in lesser gestation babies also. So it's a rare condition. And what happens? Lichteromnia also decreases, and then most of the times it will be meconium stain. After 40 weeks, there is tendency towards meconium. In the placenta, there will be aging of placenta, and this is manifested by excessive infarction and calcifications will be more. Next, cord, there will be decreased water and jelly, and which may restrict cord compression. So, lesser the jelly, more the cord compression. When the patient is in labor, every time with each contraction, there is every chance of cord compression, again, hypoxia to the baby. So what are the complications? During pregnancy, there will be diminished placental function, there will be oligohydramnios, there will be meconium stain liquor. So all these are unfavorable to the baby, leading to fetal hypoxia and fetal distress. So during labor, what happens? Again, the stress of labor adds on fetal hypoxia, acidosis, labor dysfunction, because the baby is big. There will be prolonged labor. Labor won't be progressing normally. Dysfunction. There can be shoulder dystocia. Next, meconium aspiration. If the baby aspirates the meconium, meconium aspiration syndrome. It's again a perinatal morbidity and mortality. And the risk of cord compression. Amniotic fluid is less. Water jelly is less. So with each contraction, there is chance of cord compression. Cord compression means again lesser the oxygen and nutrients to the baby and hypoxia to the baby. Next, if you deliver the head as the baby is overgrown, the shoulder diameter will increase and there is every chance of, and the muscle, everything will be grown, there is chance of shoulder dystocia and increased chance of birth trauma. You struggle to deliver the big baby and more the chances of birth trauma to the baby. What happens to the baby in difficult delivery? There is every chance of clavicle fracture, humerus fracture, or nerve injuries, Erb's palsy, Klumpke's palsy. You all know, you will read in shoulder dystocia. So these are all more with the baby and non-molding of the head. So this is all birth trauma, hypoxia, and more the chance of stillbirths also. This is in case of labor. And there will be increased instance of operative delivery. And the baby is not forming. What will you do? You have to opt for instrumental delivery, means forceps or ventouse. Then also trauma to baby and also the mother. And the mean clinical significance of postpartum pregnancy is dysmaturity or microcephaly. Baby will grow big. So following birth, what happens? If there is meconium aspiration, it can cause chemical pneumonitis, atelectasis, or even primary pulmonary hypertension due to meconium aspiration. And if there is hypoxia, the baby will go into hypoxic ischemic encephalopathy or even respiratory failure, hypoglycemia, polycythemia, and increased NICU admission. So perinatal morbidity mortality is more. Stillbirths or more. The risk of stillbirth is increased by about threefold from 37 weeks to 43 weeks. So there will be difficult delivery and trauma to both mother and baby. So this is meconium aspiration syndrome. Here the aspiration of amniotic fluid which is contained in meconium. This meconium aspiration, meconium can be thin meconium strain or thick meconium. Because if the baby faces hypoxia, the baby passes stools after delivery usually. What happens is here the baby, the first stools, you call it as meconium, it will be passed inside the uterus itself. What happens? It will be mixed up with the amniotic fluid and the baby swallows it. If there is aspiration, you have two types, thin meconium strain and thick meconium strain. Thin meconium strain is much more dangerous. Here, so if the baby aspirates into the lungs, what happens? There will be meconium in the lungs and respiratory failure and all other complications, pulmonary hypertension. Okay. See the diagram. The amniotic fluid is stained with meconium and it is again the baby is swallowing it. So mechanical aspiration, it can cause mechanical obstruction, air trapping and uneven ventilation, or it can cause chemical pneumonitis, chemical inflammation, or surfactant inactivation leading to atelectasis and intrapulmonary shunting, and finally hypoxia, acidosis, or primary pulmonary hypertension interchangeably. Okay. So how will you manage? So the patient came to you. When the patient comes to term, you have to counsel her regarding delivery, labor and all. Each antenatal visit she comes to you, you have to explain when her next visit will be. So for the first first trimester, like you will call every month. Okay, till 28 weeks, it is fine. Next, you call every 15 days. And if she touches 36 weeks, then you call every week. Or if she enters into labor or some other complication, she has to report to you immediately. So, but now if the patient is already post-term, she came to you, and how you manage now, it can be grouped again into uncomplicated and complicated. Uncomplicated means simply dates are passed and no other complication, no other obstetric or some other complication. Then how will you do? You can go for selective induction. The pregnancy is even till 41 weeks, you can allow or you can wait for spontaneous labor, because compared to induction, spontaneous labors have always better chances of successful vaginal delivery. So the pregnancy is allowed to continue till spontaneous induction, but you have to take care of the baby. Means fetal surveillance and biophysical profile you have to do twice a week. Otherwise, routine induction. What we practice routinely, this one only. Here, you wait for 7 to 10 days past your expected date of delivery. If she enters into labor, fine. Otherwise, we will start medical induction. Okay, so this is routine induction. This is a story of uncomplicated pass rates. If it is complicated, means already she is case of elderly primigravida, precious pregnancy, preeclampsia, RH incompatibility also. You should not allow her to go to post dates. Okay, because more the chance of fetal maternal blood mixing and fetal compromise. If the baby is not good or if there is oligohydramnios, then you have to directly go to elective cesarean section. And if the associated complications that are likely to proceed, placental insufficiency also, you should not allow to go post. That is why if the patient is having diabetes or hypertension or any other disorder, 37 completed weeks, we only start terminating, because as she goes towards term and post term, it's likely we are going to lose the baby and more the complications to mother also. So that's why we won't allow them to go to complete term also. So in those conditions, you have to go for elective cesarean section. So post maturity ensured. Then fetal surveillance, how will you do? NST, amniotic fluid index estimation, biophysical profile, Doppler study. By doing these studies, you will come to know whether it is complicated or uncomplicated. If it is uncomplicated, wait for 7 to 10 days. If no labor, start induction. On induction, if the cervix is ripe, means it is favorable for delivery, then you go for stripping of membranes, ARM, artificial rupture of membranes. If it progresses clearly, the amniotic fluid is also clear, then you have to start oxytocin drip and you can go for expected vaginal delivery. If the cervix is unripe, then you start induction with the help of what we do routinely, Cerviprime, prostaglandin E2 gel 6 hourly. The cervix is dry, then ARM, then ARM means artificial rupture of membranes. You will see with the help of corpus forceps, you will rupture the membranes. You will see the liquor color. If the liquor is clear, then again our oxytocin drip and expected vaginal delivery. Here, if after ARM, if the liquor is meconium stain, then you have to go for amnio infusion not done routinely. You can go for electronic fetal monitoring. If the baby is doing good, you can allow for vaginal delivery. The scalp pH estimation also not routinely done. If the baby is not good, if there is fetal acidosis or if the baby is not good with our NST, during labor also you can go for continuous electronic fetal monitoring with the help of NST machine. Then you have to go for cesarean section. So this is uncomplicated. If it is complicated, an inclination towards cesarean is if the cervix is completely unfavorable, cesarean section. If it is complicated, still the cervix is favorable and she is likely to go into vaginal delivery, means she's already in labor, you can do ARM, artificial rupture of membranes, and followed by our continuous electronic fetal monitoring. If the baby is good, the amniotic fluid color is clear, then you can go for oxytocin drip and expected vaginal delivery. If you found meconium, in case of ARM, meconium stain like then again the baby continuous fetal monitoring if the or scalp pH electrode. If the baby is having acidosis or the NST is not good, fetal heart rate is not good, if you found decelerations, if you find no variability, no accelerations, so these are all the things which are non-reassuring NST. So then you have to immediately go for cesarean section, or if the fetal behavior is satisfactory, the NST is good, everything is good, then the labor is progressing well, then you can go for expected vaginal delivery. Okay. Hello. Hello. Divya, attendance అయిపోయిందా? సరే లక్ష్మి పిలిచేసా. Okay guys, you can leave. Thank you.